Good morning. My name is Sudha Shivaram, and I'm a program director at the NCI Center for Global Health. Thank you for joining us today for our Global Cancer Research and Control Seminar Series. This seminar series features talks by researchers and cancer control experts working in global oncology and provides opportunities for discussion and collaboration on impactful and innovative work addressing cancer morbidity and mortality worldwide. Today, I'm delighted to welcome Professor Isaac Alatise and Dr. Peter Kingham to present on their work with colorectal cancer screening, biology, and treatment in Nigeria. Together, Drs. Alatise and Kingham have conducted multiple prospective studies on cancer in Nigeria. They have also co-founded the African Research Group for Oncology, which runs a clinical database and biobank for colorectal and breast cancer. Dr. Isaac Alatise is a professor of surgery at Obafemi Awolowo University in Nigeria, where he also acts as a consultant general surgeon at the teaching hospital. In this role, he has trained over 30 general surgeons interested in surgical oncology. Dr. Alatise trained in surgical oncology at Memorial Sloan Kettering Cancer Center in New York. And in 2016, Dr. Alatise was selected as one of the 50 for 50 future cancer research leaders by the International Agency for Research on Cancer. He holds multiple high-level positions in national and international cancer organizations. Dr. Peter Kingham is a hepatopancreatobiliary surgeon at Memorial Sloan Kettering Cancer Center and serves as the director of the Global Cancer Disparities Initiatives there. Dr. Kingham graduated from SUNY Stony Brook Medical School and completed his residency at New York University before becoming a research fellow in hepatic immunology. Dr. Kingham is most interested in determining ways to improve cancer care for patients in low and middle-income countries. Together, Drs. Alatise and Kingham lead the Nigeria Cancer Training Program that seeks to develop cancer research capacity and mentor early career researchers, including clinicians in Nigeria, in the conduct of rigorous cancer research. Before handing the session off, I'd like to review a few logistics. First, please save your questions for the designated question and answer time immediately following the presentation. You may type your question in the chat box or use the raise hand feature found under reactions. Second, please note that today's presentation is being recorded and will be available on our website at cancer.gov/globalhealth. Finally, you can find information about future presentations on our website and by following us on X at NCI Global Health. Now, we will begin our presentation. Welcome, Dr. Alatise and Dr. Kingham. Over to you.
Thanks, Sudha. Appreciate the introduction. I'll load up the slides here. Great. So Isaac and I are going to split this presentation up. I'll do the first half, and then Isaac will do the second half. We're both really honored to be here to present the work that our group has been focused on for over 10 years in Nigeria in ARGO, our African Research Group for Oncology. And today we're going to talk about colorectal cancer in Nigeria, early diagnosis and treatment. Neither of us have conflicts. So cancer obviously is a growing problem in LMICs, with the majority of predicted people with cancer by 2050 living in LMICs. And colorectal cancer is a top 5 cancer in most countries, yet it's extremely rare that you hear about it. There is a lot of attention on breast cancer, cervical cancer, prostate cancer for very good reason. But when you look in most countries, it's the number 3 or 4 cancer commonly, but yet not nearly as much focus on research and training. This photo is of our index patient for myself and Isaac. This was about 15 years ago. That photo was taken at 2 a.m. when Isaac and I were doing a diverting colostomy for a young man who had a blocked rectum from a tumor. You can see he's quite skinny, but his abdomen's very distended because of his bowel obstruction. And he was in his mid-20s, and he had a spread throughout his abdomen, peritoneal disease. And the pattern and even how the metastases looked and feel was just different than what I was used to. And at 2 a.m, we started talking about how different the patients in Nigeria are from the US. And this sort of led us down this pathway trying to investigate colorectal cancer in Nigeria. As a part of this, we formed the African Research Group for Oncology, or ARGO Consortium, focused on research, training, treatment, and outcomes, with the goals of improving outcomes for cancer patients, performing clinically meaningful research, creating a model that can be replicated, and career development. We've broken down our research focus into 5 main areas: epidemiology, biology, screening, diagnosis, outcomes, treatment, and access. And we'll touch on these today. Obviously, this is in a circle. You could draw lines across as well. All of these are interconnected. So one of the first things that we did was create a prospective database, because one of the lessons we took from our mentor, Murray Brennan at Sloan Kettering, was the power of data and the power of prospective data collection. So that allows us to describe things like the median age of colorectal cancer patients in Nigeria, 53 years, and a significant proportion younger than 50, given the youthful Nigerian society. Also, we have prospective data on patient stages when they present, and this is really important to have baseline stage and survival data, because as we start talking about interventions, if you don't have this baseline, it's really difficult to know if interventional trials are positive or negative. So we know that the majority of patients in Nigeria present with stage 4 or stage 3. It's extremely uncommon to have someone with stage 1. The stage 1s seen in the US are mostly patients with colonoscopy screening that are finding very early stage tumors. And we know that overall survival is quite poor, 1 year survival of less than 50%. As a liver surgeon here in the US, the number one thing I do is operate on patients with stage 4 colon cancer in the liver. And we talk about 5-year survival rates for those patients, not 1 year survival rates. So this is clearly a result of very late stage presentation, which is something that we will talk about as we move on here, strategies that we're working on to try and minimize this. Now, when Isaac and I first started down this road, he and his colleagues said to me, nobody talks about colorectal cancer, but if you ask a general surgeon in Nigeria, most people will say a third to a half of their ward has patients with colorectal cancer on it. And that is a newer phenomenon in the last 5 to 10 years. And while the data are hard to evaluate, because the data from 15, 20 years ago, there's not a lot of prospective data, it does appear like there are at the least a lot more patients presenting to healthcare facilities with colorectal cancer. So this led us to ask, what are the risk factors for colorectal cancer in Nigeria? And there's clearly been a huge shift in the last 10 to 20 years. Traditionally, everybody lived quite rural life. This is a woman who's quite skinny, pushing stuff to the market. This is modern day Lagos, people in traffic, environmental exposures change, sedentary lifestyle, processed food. So there's this whole shift in culture that likely is playing some role in this change in colorectal cancer risk. So we got an R01 with myself and Isaac and Margaret Du, who's an epidemiologist at Sloan Kettering. And this is a case control study. It's 600 cases, 1,200 controls. We're just ending our last year, going into our no-cost extension. We're at about 560 cases of the planned 600. And the epidemiologic side of this is a diet and exercise assessment that was based on the Nurses' Health Study that adapted with Nigerian epidemiologists and nutritionists. And this was validated in Nigeria with food diaries and photo documentation of meals. This is just sort of a snapshot of some of the items that are listed on this. And the goal was to try and figure out what known colorectal risk factors are relevant in Nigeria, and are there novel risk factors as well. The other half of this R1 is a genetic study, which we'll get into in a bit. So these are brand new data. We're just working on some of the analysis of this. And so we've been looking at dietary patterns and their association with colorectal cancer. Most of these studies previously have been carried out in high-income countries. The few studies in sub-Saharan Africa are focused really on isolated nutrients and food types, not dietary patterns. So the methodology for this was looking at the time, 507 cases, 1,114 controls, and we used 3 empirical dietary patterns: diversified, African traditional, and westernized. And there were 3 index-based dietary patterns: DASH, AHMED, and AHEI 2010. And you can see here that these are many of the common subtypes of food that were evaluated in this. And these were linked with the diversified, African traditional, and westernized dietary patterns. And the AHEI 2010 dietary pattern was statistically significant in having a protective relationship with colorectal cancer. So these are brand new data. Actually, I pushed them to provide this before we had this talk, so we just got this this week. And this is work from Adelaide Adiome, who's a Nigerian epidemiologist who's part of our D43 program and is spending a postdoc year at MSK. Has been working on this with Noah Piri, an epidemiologist, with Margaret Dew at MSK. And so as we finish our case control study later on this year, we hope to have added more patients to this and see what conclusions we can gain. We did look at established risk factors for colorectal cancer, and they're pretty uncommon in the study population. So just to give you an idea about who's in the case control study. So the age, median age is in the 50s, fairly evenly split between male and female. The majority had secondary school or university education. BMI less than 18.5 was the majority of patients. This is likely both a reflection of a society that has a lower BMI than, say, the US, but also, especially for the cases, patients who are coming in late stage with cachexia. Majority of patients never drank alcohol or smoked cigarettes. Now, in looking at when these risk factors were present, some of them were associated with colorectal cancer, family history of any cancer, and family history can be challenging to get detailed information on, but we do ask a number of questions about it. Height, METs per week, looking at activity, and alcohol, ever versus never. These were all adjusted for age, sex, tribe, geography, occupation, education. I didn't show the BMI here. There was a strong association with cancer, but this is likely associated due to late stage and cachexia. There's another component of that. Yeah, okay. I just wanted to make sure I didn't put that slide in. There's another component of the case control study, which we are just getting the data back on, and that has to do with environmental exposures. And we did get a pilot to go along with the R01, and these patients, the people in the case and control study, about 40 of them wear silicone wristbands, and this is as part of the HHEAR program, and those data are just coming back to us, and there may be some interesting differences in exposures there. This is a small pilot, and we're hoping to expand this. The other thing of note from the case control study was that the majority of Nigerians were unaware of colorectal cancer. And these data are pretty interesting to see. So if you look at, we asked them awareness of breast cancer and if they'd been screened, and really the strong majority are aware of breast cancer, which shows the effectiveness of public awareness and education campaigns. Although the minority of women were screened for it, this is something that people have heard of, whereas this drops off significantly when looking at cervical, colorectal, and prostate cancers. Now, we've also been focused on looking at some of the biology of these cancers. And so the other half of our R01 is doing MSK Impact, which is a 500 gene panel done at MSK, looking at commonly mutated genes in cancer. We will have about 400 patients' data from the case control study. We also got a supplement to do whole genome sequencing that of about 250 patients, and that's looking at cases and controls. We do have a germline component of this. We're I'm going to show you the data that's sort of our pilot data. All the data from the R01 case control is under analysis right now. Then probably the most interesting part of this is we will have all of this genetics data in the same group of patients that we all have all of the nutritional and environmental and epidemiologic data on, which makes it a very unique data set. So then we're going to have to combine the two aims of the R01 and see what sort of crosstalk there is between the two different fields. I think we may see some interesting associations there. So we started by looking at microsatellite instability and common mutations in 159 Nigerian patients. And we did microsatellite instability analysis in all 159. We did MSK impact in this pilot, 65 patients, and a methylation analysis in 25. And what we found was that the MSI high rate was much higher versus the MSK patients. If you go to TCGA, the Cancer Genome Atlas, it's 14%, so still only half of what we see in Nigeria. There's no BRAF V600E in the MSI high patients, so this suggests it's germline predominant and less than 1/3 were MLH1 methylation. The reason why this is significant and clinically meaningful is because we know that in colorectal cancer, MSI high patients don't respond as well to traditional 5-FU-based chemotherapy. This is known for stage 2 and 3 patients, and can have unbelievable responses to immunotherapy. There was a study published last year from Sloan Kettering of about 18 patients with locally advanced rectal cancers who were all treated with immunotherapy. This was a lead article in New England Journal, front page New York Times. All 18 had complete pathologic response, and none went on to surgery or radiation. So we think this is extremely clinically meaningful because it means almost 1/3 of patients have an alternative treatment to what they're currently offered, which could have a drastic improvement in response. And it also could mean that the 1/3 of patients who are MSI high, who are currently going into financial toxicity and getting all the side effects of 5-FU-based chemotherapy, are being treated with a treatment that is really suboptimal. So later on, Isaac will talk about the immunotherapy trial that was generated out of this. We're really quite careful when we're trying to pick our studies to make sure that they pass the litmus test of being clinically meaningful. And I think we'll show you why we think that some of this biologic determination of Nigerian colorectal cancers is quite clinically meaningful. It's also raised the question if there's an alternative molecular pathway in these MSI high Nigerian patients. The Lynch syndrome percentage is similar to the US. In the non-Lynch patients, typically it's epigenetic methylation of MLH1 that causes the majority of somatic MSI high colorectal cancers, but less than 1/3 of the Nigerian patients demonstrated this versus the majority in TCGA. There's subclassifications of colorectal cancers called SIMP, and only 8% in Nigerian were SIMP high versus 63% in TCGA. So this is one of the goals of our R01 is to try and generate a lot more data for this. Our germline analysis is underway. We haven't seen the data yet. And we're going to try to do some methylation analysis as well. So our hope is that about a year from now, we'll have a much bigger picture of if there is maybe an alternative molecular pathway in Nigerian patients. We did look at some of the common mutations, the Wind pathway, which is mostly represented here by APC mutations. The first column here is Nigerian patients. The second is MSK impact in African-American patients. The third is MSK impact in other races, mostly Caucasians. And you can see a significant drop in APC mutations. APC mutations are usually associated with better outcomes in patients. Then we looked at that RAS, which is mostly KRAS mutations, and it's more common in Nigerian patients compared to the two cohorts at MSK. This is also clinically relevant because the EGFR inhibitors do not generate a response in patients who are KRAS mutant. So there is some clinical relevance there. We'll get a much bigger update on these patients when we complete the R01. Now we're going to move on to screening and diagnosis, and I'm going to pass it over to Isaac to take forward the rest of the talk. Isaac?
Yeah, thank you, Dr. Kingham, and thank you for the opportunity to be here. Like Peter said, we've had a database that has been looking at colorectal cancer, and the data was clear that majority of our patients are presenting at very late stage. And because they are presenting at late stage, anywhere in the world, the outcome of management is not as good as when we see them at early stage, which is the similar stage where most of those patients in advanced country, most of the developed country present. So, and that's why we were so much interested in looking at screening, early detection strategy. How can we get some of this cancer very early so that our outcome of management can be better? Of course, there are no prospective trial for any colorectal screening in sub-Saharan Africa. And so it was so difficult to even introduce anyone. Is it feasible? And what are the high-risk group that can be used? How easy will it be to introduce such into a system that will not overwhelm the system with the limited resources that is available? Generally, most big organizations will recommend FIT as for organized opportunity screening program. We question this because this is not backed up with data. It's just based on the resource, based on what they feel the resources should be able to accommodate in low-middle income country. But we are very much aware, practicing in this part of the world, that there are unique set of problems associated with doing stool-based testing in Nigeria. Next. So we've looked at several screening modalities. We've looked at FIT. We've looked at which was being recommended. How feasible is it to use this in our environment? We've looked at other modalities, which I will quickly go through within the next few minutes. So we look at FIT in average risk population, and we're also considering it in first degree relativeness. We conducted a prospective FIT study in 3 Nigerian states, north central and southwest of Nigeria. We recruited about 2,330 participants from these 3 communities. Individual average asymptomatic average risk participant from age 45 to 75. And our return rate was quite high. And majority of the patients that are participants in these studies shows that it's something that is easy to perform, and they were willing to undergo the tests subsequently. However, what we found was that the fit positivity rate was so high, about 21%. In most advanced countries, it's usually between about 3 to 10% at most. But in our own setting, we found about 21%. And we conducted a free colonoscopy for almost all of them. Only 66% of them came despite the navigation, showing that we need to understand why, even in the setting where this is being offered free of charge, there are some unique things that need to be overcome for people to participate in this type of program. Because of high false positivity rate that we have, our positive predictive value was very low, which is just for basic cancer was just 1.1%, and for advanced adenoma was 7%. It was lower compared to what has been reported in from literature from high income country. They quote data in the above 20%. In fact, some reported data of close to 50%. So false positivity rate that we see was essentially due to internal hemorrhoid and diverticulosis that we see in some of those patients, which is also unique because up to recently, diverticulitis or diverticulosis was said to be low in our environment. So based on this data, we know that doing a qualitative FIT test it's not something that is quite very, very useful in our environment. And it is probably because the incidence of colorectal cancer is quite low and not making this screening modality to be the appropriate for us. And the question is that is the same pathway that is being recommended in high-income country. Does it mean that It's not the usual, just like Peter said previously. So we were looking at, because we can't afford to give up, looking at what other method can we use. If FIT that seems to be recommended is not seen to be appropriate for our environment, what can we do? How can we get this patient early? And we looked at our colonoscopy data and our colorectal database. We found that over 90% of these patients have symptoms that have been there for more than a year, and especially rectal bleeding. And we felt that, okay, let's explore this. And we looked at this data. We recruited 362 patients from family physician clinic, those that presented to them with rectal bleeding, 45 years and above, rectal bleeding more than 1 week. We conducted clinical examination and free colonoscopy for this patient. Lo and behold, the result that we found looked intriguing to us, because we found we did this in 3 academic centers in 3 states in Nigeria. So it's not just one state. My center was a training cohort, and the other 2 centers were the validation cohort. And the amount of colorectal cancer cases that we found in those training cohort and the validation cohort was far compared to what we reported from our FIT. And next slide. Based on the symptoms that the patient presented, we were able to come up with an algorithm that can help us to diagnose colorectal cancer early. So we found that patients that have weight loss, change in bowel habits, and rectal bleeding, 1 out of about 50%, and 1 out of 2 or 3 of them are likely going to be having either colorectal cancer or a form of advanced adenoma. And that is something that we feel may be feasible in our environment to deploy in large scale. Next. So what's from the fact that we are able to identify more cancers using these modalities? If you look at this slide, you see that majority of the cancers were early stage 2, stage 3. Next, if you see what we have currently in our data, stage 4 was 54% of our cohort. Now we were able to drop it to about 21%, showing that with this early diagnostics strategy, we may be able to begin to pick any cancer at any stage compared to current strategy that we have. Next. So the goal is to can we scale up an early diagnosis program with a goal to decrease the delay in diagnosis and increase the increase the ability to diagnose this cancer early. But because the data suggests time between the first presentation, when they have those symptoms, and the time that the definitive diagnosis was made, there was actually very wide. And using that, if we can now shorten that gap, we may be able to have a stage migration from stage 4, stage 3 to less than lower stages like stage 1, stage 2. And because of that, we started a pragmatic trial in Osun State where we are using a constellation of symptoms. We move beyond just lower GI bleeding, rectal bleeding, weight loss. We brought in other common symptoms that patients with colorectal cancer do present with in our environment. And we've piloted it in 2 local governments where we found extraordinary findings. We are just rounding up this month, and hopefully we'll be able to present the data when we have the next opportunity. Based on the interesting data that we have from this pilot data, we are developing a state-wide cluster randomized trial in other local governments that were not covered, in which we would stay in each of those local governments, roll out this program of any detection strategy using symptoms, and this will be rolled out within 60 days, and other locations will serve as control, and we'll be moving from one local government to the other, so that we can, the results is promising, as we saw in our pilots, we will be able to recommend this at a national scale, and probably recommend this to other low-middle income countries as a better way of diagnosing colorectal cancer early. Next. We are, aside from looking at the stool, looking at the clinical symptoms, we've also looked at other modalities by which we can get this cancer early. We've looked at blood, we've looked at urine, and we were funded by NIH to look at working with University of Alberta, MSKCC, and ourselves, and some institution working with us in Nigeria. We gathered about 650 Nigerian urine. We put that through mass spec at University of Alberta, and from this, that funding was to develop a front-end device for colorectal cancer. After identifying those metabolites that were unique for colorectal cancer in our environment. So, some metabolites was identifying diacetylspermine, hydroxyimpuric acid, and glutamate to be the best metabolite that fits into Nigeria patient, US patient, and Canadian patient. And based on this metabolite, the metabolites, when we look at their sensitivity and positivity, it look at the area on that curve look to be promising. When we were doing this, when we roll out this program, our desire is not to use it to diagnose colorectal cancer, but to reduce the need for colonoscopy. Because if we were using FIT, we'll be doing needless numbers of colonoscopy that the system cannot accommodate. So we're looking for more sensitive device that can help us reduce the amount of patients that should be undergoing colonoscopy that will not overwhelm the system. So our target is to have sensitivity of about 80% and specificity of about 50%, and which some of these metabolites that we identified seem to fit in very well. And when we had them with some clinical factors like blood is due weight loss, sensitivity rise above 90%, and specificity still remain about 50%, and the area that seem to be very important. So a point-of-care device was developed, which we'll see in the next slide, which has a chamber. If you can see, there's a chamber where the urine will be placed, and it's an automated machine. The patient urine is collected, and the patient information is put into the computer, and as soon as the machine is powered on, it's automatically run the metabolite on the urine, and you have the result, the readout from the handheld device. And this was something we are currently analyzing data. We've done a pilot of this in about 80 patients, and the result we got is not so discouraging. Right? At some point, we thought probably we are not there yet, but we are hopeful that we can continue to push this further using other grant mechanisms to be able to identify the usefulness of urine metabolites in early diagnosis of colorectal cancer. Like I said, we've looked at blood methylation panel, and we are currently working, next slide, we are currently working with Johns Hopkins University and other universities to be able to diagnose colorectal cancer using the blood. And the reason why we did this was because of the promising results that was gotten from one of our, a member of GCDI and ARGO, that Inc., working in Tanzania, also working with the local pathologist in Tanzania. They found out that using a STRAT4 machine, you may be able to improve the hormone receptor testing for breast cancer. And that result looked fascinating to us because, like in Nigeria, almost local governments in Nigeria have this machine, GeneXpert machine, deployed free of charge. And they are currently rolling it out for TB diagnosis. So this is a machine that is readily available. We are hoping to take advantage of this type of machine and develop a colorectal cancer device that can be used. So we were funded by NIH. working with an academic and industrial partnership. The PI is Sarah Sukuman in John Hopkins, working with MSKCC. CEFID is our industrial partner with MSKCC and ourselves. We are hoping that this in the next few years, with this our first year, we just recruited the first set of patients. I mean, I think we are around about 100 patients that are just recruited. I will be using that samples to test the device that is being developed. Now, in all this, colonoscopy is very important. Endoscopy access is a must if you want to conduct and have a sustainable early diagnosis strategy for colorectal cancer. And that's why we did a need assessment for endoscopy in Nigeria, which you can see on the left side of the slide. Looking at how many states in Nigeria, how many people actually have access to colonoscopy. Forget about what's the quality of colonoscopy that is being done there. We are interested in looking at the access to colonoscopy, our current access in colonoscopy. Only about 250 centers in Nigeria perform colonoscopy routinely, and some of them are not even perform colonoscopy. Some of them are not routine. And the access is only maximum in southwest of Nigeria, and is very sparse in other parts of Nigeria. That's why we have developed a training program to be able to train the local on how to do colonoscopy. And in 2 weeks' time, we'll be starting. We were funded by ARGO grants to be able to conduct a training program for conduct a colonoscopy training course in Nigeria. And this training course is not only just to train the people, but also to develop a model that can be used subsequently to train people. We have developed an high fidelity model that we procure from the grant. And we also ingeniously developed a low fidelity model that was built by the technician in Nigeria, so that we can, if this work during this training program, if the trainee find it very useful, it's something that we hope to recommend to most training institutions in Nigeria, so that the residents can continue to use this low fidelity model, and they can learn endoscopy. They can develop their endoscopy skill not from when they are even training as a surgeon or as gastroenterologist. That's something that we hope will change the workforce, colonoscopy workforce in Nigeria. And if we are able to achieve much, we'll be able to recommend it to other low-middle income countries in Africa and other parts of the world. We are much also interested in the outcome of treatment of patients. And like Peter said, based on our results from our genetic analysis, we are starting a translational research leading to an immunotherapy trial for colorectal cancer. Like Peter said, the result coming on the use of PD-1 blockade is so unique. And even of mismatch repair deficiency metastatic colorectal cancer, the locally advanced colorectal cancer in the environment is highest compared to what is reported from other world. This is the study that should be done in our environment. And in the next 2 months, we will start to evaluate the overall response rates to this PD-1 blockade in Nigeria. And our secondary endpoint is to evaluate the progression-free survival and the overall survival and the germline mutation rate when these patients are placed on this agent. We've been able to conduct a number of training in preparation for this trial, and we are hoping to roll it out in the next 1 or 2 months. It's a phase 2 open-label single-arm study, and we are using a Simon 2-stage design, and anti-PD-1 therapy will be deployed to all those patients that have metastatic disease until progression of the disease, and or when the patient withdraw. But if the patient does not withdraw, this will be administered for 24 months and see what is the response that we are getting from the patient. Actually, we have 2 cohorts. We have locally advanced cohort, and we have metastatic cohort, and we'll be recruiting patients into these 2 cohorts. the data that Peter talked about, they were looking at the response rate of locally advanced breast colorectal cancer to PD-L1 blockade. And those patients does not need anything. They don't need radiotherapy. They don't need surgery. And I think that's the kind of thing that my patient wants. They'd love to have something that will send them away from theater. In fact, some of the reason why some of our patients present very late is because they present first to one hospital, they told them about cancer, and the next day they disappear to religious bodies and some alternate medical health care workers. So if we are able to present them with this kind of therapy that can prevent them from having surgery, from radiotherapy that they cannot even afford, and we don't have an insurance to cover them, I think that would be a game changer in our environment. So we are very, very excited. We are not only doing research, we are also doing a lot of work in training. In training, we have monthly call where Nigerian faculty present colorectal cancer cases, and we discuss what's the best management strategy. We have people from North America joining from different institutions, joining and giving advice. And it's a win-win because everybody is learning. We are learning how the Nigerian patient present, and they are also learning how this patient should be managed. And it's a monthly call that we have almost every month. Close to 50 people are attending the program. We've also been working on access to colorectal care. We've been able to look at what is the financial toxicity of colorectal cancer and breast cancer in our environment. And of course, 75 to 95% of our patients experience financial catastrophe because they have cancer. And it's because we don't have quality insurance, health insurance mechanism in Nigeria. When we presented this data to our government, that motivated them to introduce Cancer Health Fund that is now being deployed nationwide to support those patients who not afford any form of cancer treatment. It's still starting, it's still in the infancy. We are hoping that this kind of data can continue to change policy and help us to improve access to care. But based on that data, we are working with Juliet Lumati in New Western. We are developing initiating an intervention using a financial navigator, so that when any cancer patient is diagnosed, we attach that patient to a financial navigator that will give them an idea of a plan that they will need to treat this cancer right from the beginning to the end, and also help them link them up with people that can assist them and non-governmental organizations that are in Nigeria. So these are another exciting intervention that we are hoping to introduce. We've been involved in a number of training. Nigerian physicians and other people from Africa have benefited from fully funded Sodava Fellowship, which is a 3-month fellowship at Memorial Sloan-Kettering Cancer Center. We've been involved in oncology nursing training. ChemoSafe has been strongly part of what we do to be able to train nurses, doctors, technologists, and pharmacists on the best things to handle chemotherapy, to reduce harm to themselves and harm to patients. We've also been involved in pathology capacity building, pathology capacity program, which is helping to train. It's like a remote fellowship for pathologists in low middle income country. The first 2 guys have finished the training, and believe you me, I work with those 2. Their practice is like 100%. It's a turnaround because now I get better response. When you think about pathology responding to surgeons, and they know us to be a little bit troublesome, but they can now handle us better based on the depth of knowledge that they have from this fellowship. We are hoping another set is going through the program. This is the kind of thing that we are rolling out in low middle income country. Another important part of our training program is which is funded by NIH and also funded by Oak Foundation, is the Nigerian Cancer Research Training Program. So we have two clinicians have been trained. They have on-site training. They have online training using an expert online training program. In clinical epidemiologists, we expose them to Nature Master course, which can of course, we also have the funded D43 funded training program for scientists, psycho-oncologists, epidemiologists. That is to train this cohort of people and bring them together. This year, we've done a team science training program, and we are bringing about 60 from one side and the other trainee, the D43 trainee together to be able to develop a team science program in Nigeria. GCB has also been, it's not only Nigeria that's benefiting from this, or Africa that is benefiting from this. It's a win-win. We have fellows from MSPCC coming to Nigeria for about 6 months to 8 months, and we'll take through our cancer program, see how patients are managed, compare that, and also work in a number of research. 4 people have participated, and we have our first resident from North America currently undergoing a fellowship in Nigeria. Betty is currently with us, and hopefully she'll be finishing in 2 months, and we'll have another one. We've got another set coming. We've also had a Fulbright scholar, 2 of them that have come to Nigeria. We've got students that have also come from North America to come and learn how to do global oncology. So in conclusion, colorectal cancer is a common cancer in low-middle-income countries that need attention. Any diagnosis is vital to find curative patients, because irrespective of what we do, if we are not getting them early, we may not be able to cure them. And most of the intervention that we are doing is showing that it is possible to diagnose those cancer early. Additional studies looking at risk factor can lead to prevention. Point-of-care technology can help us overcome some of the barrier in diagnosing them early. And of course, the biology can help us tailor the treatments to the point where we have patients that can be cured of the disease. We won't stop without thanking those that have supported us in all this effort that we have mentioned. The physician-in-chief office at MSKCC have been very supportive. The international center have been very supportive. I've met with them personally many times to thank them, because they've been very supportive in what we are doing. We have philanthropists that have also been supportive to what we are doing. We have the Oak Foundation, we have the Thompson Foundation. Of course, we've also benefited from NCI in a number of ways. As you can see, listed. Cancer Prevent Foundation have been very helpful. And MSK Population Science Award has also been very helpful in some of the studies that we've conducted. In Nigeria, we have over 30 institutions that are working with us. This is a picture of all the some of the participants from each of those institutions. We are extremely grateful because we've been blessed with a number of enthusiastic scholars that have been working with us to move the frontier of science, of colorectal cancer science, further in Nigeria. So thank you.
Well, thank you, Dr. Alatise and Dr. Kingham, for such a terrific presentation. We will now open the session for questions, and we invite you to turn on your cameras if you're comfortable so that we can see each other during the discussion. As we mentioned earlier, to remind you again that you may type your question in the chat box or use the raised hand feature found under the reactions tab and wait to be called on. And when we do ask you to ask your question, please unmute yourself. And we'll get to as many questions as we can in the remaining time. So I see Ophira. Go ahead, please.
Thanks. Actually, first, just spectacular, great work, amazing collaboration, and kind of the right way to, if there's one right way. You both show such a tremendous example and exemplar of how to do this kind of research in terms of the bench to bedside and back again, all the different ways to approach a complex problem, and in your collaboration and mentorship. But question-wise, I'd like to see first if there's others, including early career folks in our shop or elsewhere who are joining who want to ask. I have a few questions, but I'll hold off for a second. Let's see if there's others.
I don't see any others, Safira, so go ahead. And I'm
Thank you.
on the lookout. Yes.
So I have a few, but I'm going to start with one thing. Super important work regarding early diagnosis and for people to understand the value of showing what's possible in clinical downstaging, especially when clinical downstaging associated with access to early treatment without abandonment. So you've got that 66% colonoscopy adherence. Yeah. So one question is the role of implementation research in that regard, which I think you have some efforts in, or behavioral research. And I'd like to hear about that, and also how that relates to, are you guys talking to the World Health Organization? Because this is very much akin to the early phases of what became the global initiative for global breast cancer initiative, right? And I just had to prepare a talk for CanScreen 5 that looks at early diagnosis even as you're developing or scaling a screening program. You may have an excellent example of this, and it's hard to come by, even in breast cancer literature. So it's kind of a multiple question: implementation research, navigation, and whether you're working with WHO, considering metrics like the pillars for the Global Breast Cancer Initiative that might be analogous. Thanks.
Thanks, Safira. The 66% is from the study that Isaac led us in 3 different cities, in patients who are FIT positive. Because of that number, for the pragmatic trial that Isaac showed, looking at this in a step wedge trial within Ocean State, which we'll find out about in June, if that's moving ahead now or being resubmitted, is we built in patient navigation, which we previously hadn't used. We have used that in a breast cancer study that's based similarly at primary and secondary centers, and we've used it in the 2 pilot local government areas where we've been doing the early diagnosis program. And in the few months that we have been running the pilot, we think that that patient navigation is going to really help increase that number. We did build in a significant amount of implementation science endpoints to this pragmatic trial with the early diagnosis strategy. So I think we will learn a lot about what works. This will take our intervention much further from Isaac's home city, which is a rural city, but we'll take it much further away geographically. So I think the implementation science component is going to be very important. And the idea that collaborate with WHO on this is a good one. We have not formally, we've had sort of talks and they know a little bit about what we've been doing, but that's a great idea, Isaac. I think for us to have a call with Andre and the team there to really lay all this out, because you're right, we're just much earlier in the story than in breast cancer, but there's a lot to learn from both sides of the story.
Yeah, and just to add, and then I'll shut up. I know there's other people who want to ask questions. Having just had to review and critically appraise again the current literature on the breast cancer side, including for a document coming out soon on patient navigation, there's actually very little high-quality research. There's a lot happening, but little research to support effectiveness, let alone other things like cost-effectiveness. So you actually, in a way, are ahead of the game because you're planning for this. You've got your sort of learning lab and have all the baseline data, and showing the reduction in the prevalence, I guess, of late stage disease is critical. People always focus on increasing early stage disease, but it's actually more important in the first instance to show what you can do with the late stage. Just for those who don't know much about breast screening epi on the call, but yeah.
Yeah, that was probably the piece of data we were most eager to look at in that study. Our fear was that we were just finding stage 4 patients, a few months before they would have presented anyway, which obviously happy to care for everybody, but the goal was to find early stage patients. We were surprised when we saw the stage migration at Isaac's institution, and then it was the same when we took it to other institutions. So that was obviously what the goal was.
Thank you. Thank you for that. I do have a question. I don't see any other hands raised, so let me go ahead and ask it, and please think of others. When you talked about the FIT test and the downstaging that you're seeing, You mentioned that the patients were recruited from the community physicians and the, I guess it sounded like primary health centers where they see the doctor first. So my question is, how are you engaging those doctors who are seeing the patients, or even these traditional providers? Are you thinking of ways to maybe educate them or train them? Are they involved in the stepped wedge trial as people who will be connecting with your research team?
Yeah, indeed. That's a great, excellent question, because that's what we actually did when we did the pilot study. The patients were recruited from the community hospitals. This, in the stepped wedge randomized control trial, they're even taking it further. Not only focusing on the community hospitals, we are going further to reach out to the pharmacists, to all the people that are tending to patients that have some form of these symptoms. When we did the pilot trial, of course, we had meetings upon meeting with everybody that were people that were treating those patients and those family physicians. And subsequently, we meet with the trade bodies, the driver organization, the drivers, the driver union, the TISAN, and everybody to let them know that this opportunity is provided to them. In the pilot that we are concluding as a prelude to this third wedge, we went to the religious body, every organization that we can contact, that we can reach out to. There are adverts going on in the radio, in the print media for every day. So there's the need of information about colorectal cancer and how they can access care. And that seems to be very, very yielding a lot of results in the pilot study that we just completed.
Thanks, Isaac. And that will go towards the health literacy rates that were low in your earlier slides. So there's two questions here on chat. The first is from Antoinette. How far down the line do you intend to bring on board countries in the sub-region or other LMICs? And Ophira has carrying on to that, any similar research in other Nigerian or African populations regarding right-left disease and molecular epi?
Yeah, definitely that's our target. You start from the core and you continue to spread out. So as soon as we are able to tidy up the data that we are gathering, our desire is to move to the next stage. And the next step will be to get other African country and NMIC. There's been a number of interest in what we are doing, and they are already looking at some of the data we've published and looking at how they can take advantage of this. Our desire is to take this further from Nigeria to other NMIC as soon as we are able to develop the core data set that we are building, so that at least we have all the story to pass across to everybody.
Yeah, I would say that we've already done some clinical comparisons with South African patients. There's 2 South African groups in Joburg and Cape Town that have linked in with us. And they're now building a biobank to sort of compete with the Nigerian biobank. They've seen what data have come out of this, and they want comparison data. So I think there's more to come with that. And there has been some preliminary data that has matched ours on MSI high rates from other countries, but otherwise very little on molecular epidemiology. So I think in another year, when we have our R01 data analyzed, I think it'll be an important contribution to the literature.
We just have a minute left. Paul, up to you.
Hi, Isaac. I'm Peter. Good to see you both. I apologize if you already addressed this. I may have been distracted by something shiny, but there's been some studies that have sort of pointed out that room temperature stabilization per fit has some potential challenges that reduces hemoglobin, and as a result leads to some susceptibility to false negatives. And I was just curious what you all have been seeing.
Oh, great. Before we did the 2,330 pilot that we did a small pilot in which we were looking at the role of environmental temperature in FIT. And those that were positive for FIT, this has been published. It's already been published. Is in the literature. So those that were positive, we left them in the open air for 48 hours, 72 hours to see if some of those kits will turn negative. And we found out that after 48 hours, some of those kits were actually turning negative. Those that were positive were turning negative. And that was what we used. We used 48 hours maximum for the return of the stores, the kit to us when designing the pilot study that I talked about. So we did small pilots looking at the role of environmental condition with the role of parasites in the positivity rate. And we found that they were not that significant. And that was why we didn't pay more attention to that in the final pilot that we talked about.
Thank you. That's really
Well, thank you. Thank you very much. This was a fantastic presentation. Thank you for your time, Peter and Isaac. So it concludes our session today. Please remember to join us for our next session on June 13th with Dr. Rahul Parmar, Dr. Gaurav Narula, and Dr. Hasmukh Jain as they discuss CAR-T development in India. Next, we'd also like to mention registration is now open for a 12th annual symposium for global cancer research, which will be held virtually from May 6th to the 9th. And we hope you'll be able to join us for what we think is going to be a great symposium. And finally, please visit our website at cancer.gov/globalhealth to find information about upcoming seminars. We also post past recorded sessions there, and also information on funding opportunities, events, news, and more. And do follow us on X at NCI Global Health, as well as on LinkedIn. So until the next seminar, be well and thank you.
U.S. Department of Health and Human Services, National Institutes of Health, National Cancer Institute, cancer.gov, 1-800-4-CANCER.